Good morning, and thank you to the TMRN for the opportunity to speak today. So I'm going to give a summary of the first part of my PhD work, which was a quantitative study of the readability and understandability of clinical research patient information leaflets and consent forms, which I'll abbreviate to PILs, ICFs. So by way of background, the patient information leaflet, the PIL, is a very important component of the informed consent process, and we know that combining written information to verbal information improves the quality of consent. However, despite the fact that we know in Ireland 4 out of 10 people have limited health literacy, and that we know that older, sicker patients have more difficulty understanding information, patient-facing documents are often written at an inappropriately complex level and usually exceed the recommendation of about 10 to 12 years of reading age. So the guidelines say PILs should be short and that they should be intelligible, but the evidence out there, and I think we would probably all agree as researchers, that PILs are getting longer and more complicated. And of course GDPR has presented us with additional challenges. So we're required to give patients even more information, often which is unfamiliar to them, and terminology that's unfamiliar to them. And it's a bit concerning that a systematic review of studies up until October 2013 found that patients' level of understanding of clinical trials essentially has not improved over a 30-year period. So the aim of this study was to assess the readability and understandability level of clinical research PILs written for adult lay people and approved within the last 5 years, hoping to take into account the effect of the introduction of GDPR. And the second aim was to compare PILs with best practice guidelines produced by national literacy agencies. So in terms of the methods, I used a combination of convenience and purposive sampling. So over last summer, we looked for investigators and academic institutions and CRFs to share any PILs that they had with us, and also some publicity through the TMRN and social media. So in terms of the first aim, to look at readability and understandability, I used a combination of two different measures. One I'll call the traditional readability measures, which focus on syntactic and semantic complexity, so things like the length of words, the length of sentences, the number of polysyllabic words. And I also looked at health literacy-based model, two criteria based on health literacy models. So the combination of these two approaches gave a broad assessment of the readability and understandability of PILs. So it considered factors like the layout, the structure, factors affecting patients' motivation and their understanding, the description of risk and the explanation of risk, and also the interaction with the text. And then looking at the second aim, so I picked out seven criteria from the National Adult Literacy Agency here in Ireland and Plain English UK's guidelines for plain English. So you'll see there the 7 I picked were a font size of at least 12 point, the use of a sans serif font, the use of upper and lowercase headings rather than running capitals, a mean sentence length of less than 20 words, use of passive verbs of less than 20%, not justifying text, and use of 1.5 line spacing. So there's consensus that these are criteria which are used to increase accessibility, particularly those with dyslexia, vision problems, and those with limited health literacy. So in terms of the results, the first batch of PILs I analysed was 148, of which 133 were valuable. And the original aim was to just collect PILs from Ireland, but I was grateful to get some from the UK as well through the social media. So 93 of the PILs were for non-regulated, non-CTIMP studies, and 55 were for CTIMPs. And you'll see the breakdown there for the non-regulated studies. In terms of sponsorship type, 91 were for academic studies, 34 were for pharmaceutical company sponsored studies, and 20 were for hospital based, and there was a few collaborative group ones there as well. So these are the figures for the overall using the traditional readability criteria. So the Flesch reading ease there was 49.24 out of a perfect score of 100. And you look down at the bottom and see that the mean reading age was 16, it's quite a bit higher than the recommendation of 11 to 12 years. This is the Flesch reading ease put in a graph, so each red dot represents a PIL, and you see it's quite concerning that a reasonable proportion of the PILs are in the difficult or indeed the very difficult category. This is a Raygor graph of the grade levels, so it's using the American grade system, so up from the 3rd grade up until 12th grade and carrying on into college and postgraduate education. So this graph indicates that the vast majority of these PILs were written at a late high school education, or indeed college or postgraduate level. So you would need that kind of education to adequately understand them. Having a look at the health literacy-based models, looking at the Clear Communication Index, which is a criteria developed by the CDC, the mean score was 67.6 out of 100. And unfortunately, none of the documents received a score of over 90, which is recommended by the CDC. The suitability assessment of materials, which, as I mentioned, looks at layout and structure, did a little bit better, had a mean score of 6.43 out of 10, but 78.2% of these were deemed adequate, 21.8% were deemed not suitable, and none of them were categorised as superior. Because of a certain amount of subjectivity involved in this assessment, I analysed them all, and my colleague also had a look at 10%, and we had fairly good agreement in our scores. And just picked out one criteria there from these two assessments. I just thought it was interesting that despite the guidelines that strongly recommend the use of a visual or a graphic to enforce the main message of the information leaflet, 92% nearly did not use any sort of graphic, and even those ones that are used were not deemed to actually enhance the message or help to explain the message of the PIL. Interestingly, there was no difference in readability or reading age between sponsor types, so it made no difference whether the sponsor was an academic or a pharmaceutical company, or whether it was for within or without Ireland. But using the health literacy-based criteria, the understandability was significantly higher for single-site studies and for non-CTIMPs. I thought it would be interesting to have a look at pre and post GDPR. So for all of the PILs which originated in Ireland, I categorised them into pre and post GDPR. And there was a significant difference in FKGL and SMOG and FRI. So the post GDPR ones were significantly more complicated. I also had 7 matched PILs, so we're comparing pre and post GDPR, and again, complexity was significantly higher. And in terms of compliance with the best practice guidelines, only 2 of the PILs, in fact, complied with all of the guidelines, which is unfortunate considering some of these are actually quite easy to comply with. So in conclusion, the clinical research PILs and ICFs in Ireland are written at an inappropriately high reading level. GDPR has presented additional challenges to ourselves. However, it is feasible to use a health literacy-based criteria to assess PILs, and that may help enhance understandability for our patients. And also it should be just considered that layout and structure is very important for enhancing understandability, and plain English guidelines are there and very available and should be adhered to. Thank you very much for listening, and especially thanks to Sandra and Sebastian, who were very helpful with the social media publicity for this. Thank you.